Yes. Good afternoon, everyone. Today I will be presenting Blau syndrome with bilateral band-shaped keratopathy and bilateral uveitic cataract, a case report. I have no conflicts of interest to disclose. Coming to the case, a 5-year-old male child presented to the pediatrics OPD of AIIMS Patna with erythematous skin lesions all over the body since 6 months of age. Fever, knee and wrist joint pain were present on and off for the past 1 year. Diminution of vision was there in both eyes, which was gradually progressive and painless. Redness in both eyes was intermittently associated with pain. There was no significant family history. The general examination showed dry scaly skin, malar erythema, and swelling over the bilateral wrist, ankle, and knee joints. He was advised a rheumatology profile and was referred to the ophthalmology OPD. The visual acuity by Cardiffs was 6/30 in both eyes. The digital tension was normal in both eyes. On anterior segment examination, there was bilateral band-shaped keratopathy, right more than left. In the anterior chamber, the cells were 2+ with no flare. There was total posterior synecdoche, festoon non-dilating pupils with cataractous lens in both the eyes. The fundus examination, the media was hazy. So USG B scan of both eyes revealed posterior capsule to be intact, low to medium reflectivity echo suggestive of bilateral vitritis, retina choroid sclera complex to be within normal limits, and optic nerve head to be within normal limits. All these findings helped us to zero in on a diagnosis of Blau syndrome with bilateral band-shaped keratopathy with bilateral complicated cataract. The following investigations were ordered. ANA profile was negative. The patient was started from pediatric rheumatology side on injection methylprednisolone 400 microgram, injection methotrexate 0.7 ml subcutaneous weekly, oral prednisolone acetate 25 milligrams OD after food, tablet folic acid 5 microgram once a week, and tablet naproxen. From the ophthalmology side, combination eye drops moxifloxacin plus prednisolone acetate 4 times per day was started. Atropine drops were started thrice a day. Carboxymethylcellulose drops 6 times per day, and HPMC gel 0.3% at bedtime. Sequential EDTA chelation right eye followed by left eye was carried out along with bandage contact lens application. This was the follow-up after EDTA chelation. Subsequently, the patient underwent phacoaspiration plus posterior curvilinear capsulorhexis plus PCL implantation under general anesthesia under explained GVP under steroid cover. Both eyes were done at 1 month interval. These were the steps. The follow-up after 1 month showed that visual acuity in the right eye was 6/24 and in the left eye it was 6/9. So Blau syndrome, it was described by E.B. Blau in 1985 as a familial granulomatous disease of the skin, joints and the eyes. About 220 Blau syndrome cases with confirmed NOD2 mutation have been reported. The prevalence is less than 1 in a million. It is a monogenic disease resulting from mutations in pattern recognition receptor NOD2. There is a triad of dermatitis, arthritis, and uveitis. The skin involvement is generally a erythematous maculopapular rash, but can be a dry scaly rash, as was in our case. The arthritis, it is of non-destructive type and boggy in nature. The uveitis may start insidiously as a posterior uveitis, but may later on turn into a pan-uveitis. Systemic and topical steroids with disease-modifying agents such as methotrexate are the mainstay of therapy, and biologics are useful if there is severe eye disease. These were the ocular manifestations. The star-marked one were, in our case, bilateral granulomatous anterior uveitis, band-shaped keratopathy, posterior synecdoche, anterior chamber cells, complicated cataract, and panuveitis. So Blau syndrome, it remains an underreported entity in India, and also it can inappropriately suggest diagnosis of juvenile idiopathic arthritis or tubercular uveitis. So in very young children, we need to consider this diagnosis. We need to elicit a proper family history. Genetic counseling needs to be done. Prompt management is pertinent to avoid morbidity, and interdepartmental collaborative efforts are the mainstay for a good outcome, as was seen in the index case. Thank you so much. So the eye should be quiescent for at least 3 months before we can go for a cataract surgery, because if then there can be extensive post-op inflammation if we don't take this aspect into account.
And role of IOLs, which type of IOL you will prefer?
Sir, in this case, generally we should not go for any kind of acrylic IOLs or silicone IOLs. These are generally should not be advised. We should go for hydrophobic. Yes.
Will you go for hydrophobic or hydrophilic ones?
Hydrophobic ones, not hydrophilic ones.
What immunosuppression is going on for the child?
Ma'am, methotrexate.
So that's the most important, not to stop them.
Yes, ma'am.
I think
Thanks so much.